All right, folks, this is the Advanced and Basic Neurological Emergencies lecture. I know you've been waiting for a long time. I apologize for that. This is my first time to use Zoom, so please bear with me, okay? I've got to advance. All right, so national standard competencies are fairly normal for each chapter. We're going to talk about neurology and emergencies surrounding that. So here's our introduction. So according to the National Center for Health Statistics, 2 of the top 10 causes of death in the United States in 2017 were neurologic. Stroke is the fifth leading cause of death in the United States after heart disease and cancer and COPD. Wasn't long ago, about 8-10 years ago, that it was the 4th leading cause of death, and COPD was 5th, but because of advances in stroke care and interventions, it now has dropped to the 5th leading cause of death, so that is amazing. In the United States, someone experiences a stroke every 45 seconds, so super staggering. And treatments for strokes range from traditional medications like clot busting drugs to very new and innovative surgical procedures like mechanically removing clots from the vasculature itself, and surgical interventions like arteriovenous malformation repair. So it's amazing what they can do now. I apologize for sounds that you're hearing, like my phone and stuff. So just to let you know some of the other leading causes of death, this is the top 10. You can get this off of the CDC website, and you can see here that stroke and Alzheimer's disease is 5 and 6. So that's what we were talking about. All right, so we're also going to talk about seizures besides stroke, and they can be caused from a multitude of reasons. Seizures can be from trauma, so an old head injury or recent head injury, an acute incident, brain tumors, abscesses, metabolic problems like hypoglycemia and uremia, genetic disposition like epilepsy, strokes, poisonings, overdoses of medications, drugs, poison chemicals, sepsis, alcohol, acidosis, fever. And if you recall, as advanced, we talked about AEIOU tips in the basic class. That in your advanced book is found on page 862. And in the basic book, the AEIOU tips is found on 686. This is not only seizures, but altered mental status, causes of altered mental status, okay, which we're going to talk about right now. So altered mental status, pretty common presentation. It can range from a simple, partying too much, alcohol ingestion kind of thing, to falling down, bumping your head, to hypoglycemia or hyperglycemia, diabetic emergencies, strokes, seizures, so that all of that AEIOU tips thing. Neurological patients and treatments are sometimes hard to figure out, but in the field, at least, we don't have CT scans and that sort of thing, so we do what we can to rule out the easy stuff that we can fix, like hypoglycemia, and we protect them, and we move to the hospital. Neurological patients can be pretty vulnerable, so sometimes they can't blink, their eyes get dry, they don't have a gag reflex, so they can't cough the secretions that might be draining down their throat. They don't know because maybe they can't feel a side of their body if something, you know, is in an awkward position, or if you just mash their arm up against the stretcher or the ambulance or something like that. Their airway is vulnerable. Sometimes their tongue becomes, you know, relaxed and flaccid and just blocks their airways. And they cannot, because they don't have a gag reflex, cannot protect that airway. So their airway is at risk. Again, alter mental status and AEIOU tips. Okay, so some anatomy review. Now, this was in your big chapter on the human anatomy, but this is just a quick review. The nervous system, very complex set of systems and nerves, consists of the brain, the spinal cord, and all the nerves that communicate with the rest of the body. This is just a little bit about the central nervous system and peripheral nervous system. I have several slides here that kind of show you that. So the central nervous system is responsible for fundamental functions like breathing, heart rate, blood pressure, temperature regulation. Also responsible for higher level activities, parts of your brain, memory, understanding, thought, communication. And the major structures of the nervous system are divided into central nervous system and the peripheral nervous system, which I've kind of just abbreviated central nervous system and peripheral nervous system here. And we're going to go into greater detail. And some of this stuff I added into this lecture. So it's just added stuff. So here's a short video on the nervous system I would like you to watch. So please do that. I'm gonna keep going. Well, I'll go ahead and click it if I can. All right, so let's control click, I think. So here is the video I wanted you to watch. We'll do it together.
Welcome to 2-Minute Neuroscience, where I simplistically explain neuroscience topics in 2 minutes or less. In this installment, I will discuss the divisions of the nervous system. There are two major divisions of the nervous system. The first is the central nervous system, which is made up of the brain and the spinal cord. The second is the peripheral nervous system, which consists of nerves that run throughout the body. The peripheral nervous system itself is made up of two subdivisions. The first is the somatic nervous system, which contains nerves that carry sensory signals from the body to the central nervous system, and nerves that carry motor signals from the central nervous system to the skeletal muscles. The somatic nervous system is associated with voluntary movement. When you clicked on this video to play it, the signal to depress your finger was sent from your brain to your finger via the somatic nervous system. The second division of the peripheral nervous system is the autonomic nervous system. The autonomic nervous system is sometimes called the involuntary nervous system, and it is involved in regulating the internal environment of the body. It carries signals from internal organs to the central nervous system, and from the central nervous system to the internal organs. In this way, it is involved in regulating things like digestion and heartbeat, which are generally outside the realm of conscious control. The autonomic nervous system can be further subdivided into sympathetic and parasympathetic nerve fibers. The sympathetic nervous system plays a large role in stimulating and mobilizing energy resources, while the parasympathetic nervous system acts to conserve energy. For example, if you're in a frightening situation, the sympathetic nervous system will cause your heart rate to increase, your blood pressure to increase, and your sweat glands to be stimulated. If you're eating a meal, however, and are not frightened, your parasympathetic nervous system will stimulate digestion, increase salivation, and slow your heart rate. Due to these functions, the sympathetic nervous system is often described as being involved in fight or flight responses, while the parasympathetic nervous system is described as being involved in rest and digest responses.
Okay, so that was pretty informative. Oof, sorry. All right, we're going to go back. So I just wanted to show you a little bit more of the nervous system. We have the central nervous system, the brain and spinal cord, that is divided into the central nervous system controls the brain. It has the brain and spinal cord. So we have the central nervous system and the peripheral nervous system. Sorry, my brain sometimes doesn't catch up to my body or my mind. So we have information from inside the body, information from outside the body, comes along in nerves and goes to our brain, and we're able to either pick up a cup or walk away. So brain and spinal cord commands body actions, and that is further divided. The central nervous system is further divided into the peripheral nervous system, which is divided into the somatic and the autonomic. So somatic, voluntary control of muscles, and the autonomic nervous system, which can further be divided into the parasympathetic nervous system and the sympathetic nervous system. So we are going to delve into a little bit more of that. This is just another little thing. You have the structure of the central nervous system of the brain and spinal cord, and it has a lot of, processes that it does. Our peripheral nervous system, our cranial nerves, and also our spinal nerves, and those nerves are what communicates with our body and back and forth. We have sensory division, and that would be somatic and visceral sensory nerve fibers. And what does that do? Conducts impulses from receptors to the central nervous system. We have motor or efferent. Sensory is afferent. The motor nerve fibers conducts impulses from the central nervous system out to your muscles and glands. Okay. Now, the somatic nervous system we kind of talked about just in that last slide. Voluntary muscle control conducts impulses from the central nervous system to the skeletal muscles, and we're able to move and walk and blow our nose and that sort of thing. The autonomic nervous system is an involuntary thing. Conducts impulses from the central nervous system to cardiac muscles, to smooth muscles, to organs, to glands. And that, again, further dividing into the sympathetic division and the parasympathetic division. I kind of think of it as we cannot be mobilized into a fight or flight at all times. Our bodies would just poop out eventually, and it wouldn't take long. So we have to have an on switch and an off switch. Now, it's not as simple as that, because we can have both divisions working at the same time sometimes in different areas of the body. But basically, the sympathetic, as you know, is the fight or flight. That is our epinephrine, norepinephrine release, makes us either stand and fight or flee. And then we have the parasympathetic, kind of like the low key, conserves energy, promotes housekeeping functions during rest, like digestion and pooping and that sort of thing. So that is parasympathetic and sympathetic of the autonomic nervous system. This stuff is all pretty cool. This is a little picture of what happens in our body with that parasympathetic response. All right, so with the parasympathetic or the sympathetic. So if we have a fight or flight response that we are demanding that happens, we have to see that saber-toothed tiger coming after us. So imagine being chased by one. What do you think you'd do? Do you think you'd turn and fight or flee? Well, in order to do either of those, you have to be able to see that saber-toothed tiger. So our pupils will dilate. We don't really need a lot of salivary gland production. We do need to either run or fight. We have to, when we run or when we are doing something, we have to be able to breathe in a lot of air. We're going to be asking it to do a lot of stuff in a minute. So our bronchioles actually dilate. Our heart rate increases, and things like increasing our metabolic demand and our heart rate, and the coronary arteries actually dilate. So all that happens. We don't really need to digest our food as we're fleeing or fighting. So it decreases our gut motility, inhibits the activity of the pancreas. Okay, right then. So we're not going to be like storing our sugar, we're going to be utilizing it. The gallbladder is not really there to do anything because that helps in our digestion. Inhibits the gallbladder, stimulates the adrenal medulla to release adrenaline and noradrenaline, or epi and norepi. So that's one of the things it does. Relaxes our urinary bladder. And so if we were thinking about, being excited, this is what happens. Now, on the parasympathetic side, we have, we don't really need to see a lot if we're just kind of edging out. So our pupils will constrict. We're going to do things like digest now. So our salivary production is going to increase. Our heart rate's going to decrease. Our bronchioles don't need to really be full and going. So they're going to just constrict a little bit. Stimulates our digestive organs, the pancreas, the gallbladder, all of that, so that we can start digesting again. Constricts our urinary bladder. And then in the opposite of being excited and stimulates orgasm, we have, I guess, our feeder breed, if you've ever heard of that. We have the erections that we have coming here. So that was a bad joke. Sorry. I didn't mean to say that. Just laugh. Okay, so imagine that saber-toothed tiger. What do you think you're going to do? Feed and digest, or something else? All right. Again, this is another just chart that I found that helps figure out what's going on with the sympathetic and parasympathetic responses. So it's pretty cool. So a lot of things that happen. All right, the brain. What is the brain? I don't think I use my brain too much sometimes, but the brain controls a lot of things, from simple things to our autonomic responses, like pulse rate, temperature regulation, all of that, to higher thoughts, being able to remember, being able to carry on a conversation, being able to move. So brainstem controls the most basic functions: breathing, blood pressure, swallowing, pupil constriction, all of that. This is the brainstem right here. The cerebellum here is another part of the brain, and we'll talk about what they do a little bit, but it has a lot to do with our motor function and coordination. The cerebrum is the largest part of the brain, and helps with speech and thought processes and your personality and all that, and being able to see and hear. So an incredible thing our brain is. So the cerebellum controls muscle and body coordination, as we said. The cerebrum divided into the right and left hemispheres. This is the biggest part of the brain, controls emotion, thought, speech, touch, movement, sight. Usually the left parietal area is where our speech centers are, usually. So here's a little quick video on the brain anatomy as well. Just talks about the lobes and a little bit. So we're gonna watch this.
Welcome to 2-Minute Neuroscience, where I simplistically explain neuroscience topics in 2 minutes or less. In this installment, I will discuss the lobes of the brain and some major landmarks of the brain surface that can be seen from a lateral view. The brain is made up of two halves, known as cerebral hemispheres. When looking at the brain from a lateral view, which just means looking at it from the side, we will only see one cerebral hemisphere, but the landmarks I will point out are found on both cerebral hemispheres. The surface of the cerebral hemispheres is covered with a thick layer of brain tissue known as the cerebral cortex. The cerebral cortex is folded to create more surface area, forming these ridges known as gyri and grooves known as sulci. This large sulcus is known as the central sulcus. It divides the frontal lobe from the parietal lobe. This sulcus is known as the Sylvian fissure, and it separates the temporal lobe from the rest of the cerebral hemisphere. The occipital lobe is found at the back of the brain, but it doesn't have such a clear division separating it from the rest of the brain. There are certain functions associated with the lobes, but any short description of these functions is oversimplified, as each is involved in many different processes. The frontal lobes are important for movement and higher order cognition like rational thought, decision-making, and planning. This area in front of the central sulcus is known as the precentral gyrus, and it is essential for motor control as it is the location of the primary motor cortex. The parietal lobes are important for processing of sensory information and are involved in attention and our representation of the space around us. This area in the parietal lobe, the postcentral gyrus, contains the primary somatosensory cortex and is where the sense of touch is processed. The temporal lobe is involved in processing auditory signals and also is important in aspects of learning and memory. The occipital lobes contain major visual processing areas of the brain, like the primary visual cortex.
Okay. So as I'm trying to get this back where it belongs here, my PowerPoint. That was a pretty interesting, those little videos are like 2-minute videos, and I've really enjoyed watching them. There's a lot more. I didn't add all of them for sure. All right, so nerves, messages sent to and from the brain travel through nerves. We have 12 cranial nerves, that pairs of cranial nerves that run directly from the brain to parts of the head and face and ears, nose, heart. And then the rest of the nerves join in the spinal cord and exit through the brain through the foramen magnum up here. This is a picture of your cranial nerves, which I'm going to go in a little bit deeper than your books do. I just think it is important that we figure out this early in our career so that we can do a better assessment. And part of assessing for neurological emergencies is not just doing a Cincinnati stroke scale to see if they have a stroke, but to see if the rest of their cranial nerves are working and if they can walk without stumbling or kind of off balance, that sort of thing. So the cranial nerves are pairs of nerves, like I said, and they're numbered from 1 to 12 from front to back. So that's what we're going to kind of look at right now. And I like this picture because it's nice and colorful and has good definition here. So we're going to watch these videos. I'm not going to click on this 10-minute long video for you. You guys can get in there and do that yourselves. But there's a nursing instructor that I kind of liked her explanations of the cranial nerves and how to test them and stuff. But I am going to do this one.
Hiya, welcome to Biomed Sessions with me, Ruth. Today we're going to be learning the functions of the cranial nerves. Cranial nerves are nerves arising from the brain, including brainstem. They are best seen from an inferior view, i.e. the underside of the brain, and there are 12 pairs of them in total, numbered according to where each emerges. A good way of learning cranial nerve functions is by copying out and memorizing this picture, which is basically just a head with shoulders, composed of the numbers of all 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12 pairs of cranial nerves. Learn this and you'll have a pretty good idea of what each pair does. We'll go through it together. Cranial nerve 1 is the olfactory nerve. It is sensory, therefore relays information back to the brain. In this case, this will be in relation to olfaction, which is basically just your sense of smell. Handy, because the number 1 is the nose in the diagram. Cranial nerve 2, also sensory, is the optic nerve and is involved in vision. Number 3 is the oculomotor nerve. It is mainly motor, hence relays information from the brain to effectors such as muscle. Alongside cranial nerves 4 and 6, the oculomotor nerve is involved in eye movement. It is in fact related to so many eye movements that it would be best to learn which eye movements it's not involved in. If isolated, it cannot help move the eye down and out. This is the job of cranial nerve 4. And it does not help abduct the eye. This is the job of cranial nerve 6. The oculomotor nerve also has autonomic functions, i.e. those that are involuntary/unconscious. These include eyelid elevation, pupil constriction, and changes in the shape of the lens in order to focus on objects. This is known as lens accommodation. Cranial nerve 4 is the trochlear nerve. As mentioned previously, it is involved in moving the eye down and out. This actually occurs through a combination of depression, abduction, and inward rotation of the eye. Cranial nerve 5, the trigeminal nerve, is mixed, carrying both sensory and motor fibers. Tri means 3, which hints at the fact that this nerve has 3 branches which together aid in facial and teeth sensation, in addition to sensation from the front and middle thirds of the tongue, or more officially, the anterior 2/3. Also, it has motor fibers which are involved in mastication, i.e. biting and chewing. As we know, the abducens nerve, cranial nerve 6, the last of the 3 nerves involved in eye movement, abducts the eye. Abducens, abduction. Cranial nerve 7 is the facial nerve. It has motor fibers for facial expression and sensory fibers which are involved in taste from the anterior 2/3 of the tongue, not to be confused with the trigeminal nerve, which aids in general sensation to this same region. A good way of remembering the facial nerve's function is to imagine your facial expression as you taste your favorite piece of food. Additionally, the facial nerve is involved in saliva and tear secretion. The vestibulocochlear nerve, cranial nerve 8, is a sensory nerve which gets its name from the structures in the inner ear which it innervates. The cochlea, which is involved in hearing, and the vestibule, which is involved in balance. Hence, the vestibulocochlear nerve aids in these functions. The glossopharyngeal nerve, cranial nerve 9, also has an interesting name. Glossa means tongue, and pharynx is the back part of the throat. Hence, it's no surprise that it carries sensory fibers for taste and sensation from the posterior third, i.e. the back part of the tongue, and has motor fibers that aid in swallowing. It is also involved in saliva secretion. Cranial nerve 10 is the vagus nerve. Now, although I drew it really small on this diagram, the vagus nerve is actually a huge nerve which is mixed and extends further than all other cranial nerves, which is why it is referred to as the wandering nerve. Indeed, it wanders about and supplies a wide range of structures. On the sensory side, it carries sensation from the pharynx, larynx, thorax, abdomen, etc. It is also involved in taste using a flap of tissue at the back of the throat known as the epiglottis. It has motor fibers which aid in swallowing and speech, and autonomic functions such as decreasing heart rate, gastrointestinal tract contractions to aid in moving along food, and sweating. You'll be relieved to know that our next nerve, cranial nerve 11, is much simpler in terms of function. The accessory nerve carries motor fibers which help you shrug your shoulders and turn/tilt your head. And finally, cranial nerve 12 is a hypoglossal nerve, which is purely motor. If you remember, glossa means tongue, and hypo actually means under. Hence, this is a nerve that is found at the undersurface of the tongue and aids in tongue movements. Okay, that's our 12 pairs of cranial nerves done. If you found this tutorial helpful, give it a thumbs up. And if you want to see more videos like this, then do subscribe. Okay, see you in another video. Bye.
Okay, that was a pretty good explanation of the cranial nerves. So that's why I used it, because I thought it was cool. Let me get back here to that. And then, like I told you, later on, if you want to go back into this video, maybe stop it or something, and then you can click on this. It's kind of a cool, very energetic RN. For those visual learners, we have this chart here. This is kind of cool. It also tells you if sensory or a motor or both part of it. This is a little mnemonic that they use on occasion. Our trusty truck acts funny. Very good vehicle anyhow. That's a great nasty mnemonic to remember the first letters of those cranial nerves. I didn't learn it that way, and the way I learned it is a little bit off colored, but it is the only way that I can learn, that I can spit it out. So I was at a light the other day, just sitting there, and I went through all the cranial nerves because I know this mnemonic. So it was pretty funny. And I'll let you in on it, and you can write it down if you want, or you can write something else, because there's a lot of different, there's some that are Harry Potter, there's some that are just, you know, really easy to remember, but I can't remember those. I just remember the one that I learned. So, and it goes like this. Okay, and again, I apologize. I'm not trying to offend anyone at all. I'm just teaching you how I learned. So, O, 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 to touch and feel. And this is also called the, oh my gosh, the auditory, sorry. So we do an A here, auditory, for the vestibular cochlear. A, girl's vagina, ah, heaven. Okay, again, I apologize. O, 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 to touch and feel a girl's vajayjay, ah, heaven. Okay, so laugh if you want. Sorry, it's the only way I can remember it. All right, and again, for another picture, just to kind of help you out here. And there's another mnemonic here that you might, on old Olympus, towering top, a Finn and German viewed something happy. I don't know. All right. And you can, if you want, you know, print this stuff out, I think, somehow. All right, so cranial nerve number 1, olfactory, 2, optic, 3, oculomotor, 4, trochlear, 5, trigeminal, 6, abducens, 7, facial, 8, auditory, 9, glossopharyngeal, 10, vagus, 11, accessory, and 12, hypoglossal. Okay, why test them? Why do we care? Because just the Cincinnati stroke scale is not adequate enough for neurological assessment. There are many times that I have been on, say, a car crash, and somebody has hit their head on the windshield or something, And I can't, just with the Cincinnati stroke scale, I can't tell you if their brain is okay, from the field. So if I do more of a neuro assessment and get more detailed, then I'm more likely to be okay if they decide not to go to the hospital via ambulance or something, or if there is something really wrong, I can point that out and kind of steer them into, maybe it's very important that you are transported to the hospital via the ambulance. So it is helpful in detecting brain injury. Those nerves travel through distinct locations in the brain. And if I found through the cranial nerve assessment that there's something wrong in one of those tracks, it helps us figure out where their brain injury is. Minor head injuries. This exam gives us more things that we can test, more tools in our toolbox. And with vague stroke symptoms, like I'm dizzy, do a cranial nerve assessment as well as a Cincinnati stroke scale. Remember Natasha Richardson in 2009 is the wife of Liam Neeson that was skiing on the bunny hill, fell over. She did not have a helmet. She didn't get knocked out or anything like that. She got up, was kind of, ouch, and decided she I think was tobogganed down from the ski hill to the clinic, and they told her that she should be evaluated. She said, no, I'm embarrassed. So, it's all good. She went back, I think, to her hotel room and had a bleed in her head, and she died. And, I'm not saying that doing a cranial nerve assessment would have helped, but they might have found something odd, or something was just wrong, or didn't, sit right or something, and they could have maybe talked her into going, and she would have gotten a CAT scan and been okay. But we all can kind of think of, if you've been in the field for a while, situations where that your assessment and getting them to transport via ambulance and getting a CAT scan helped find something. So remember that. So there's a quick and easy exam. I've got some handouts in that you can download and print out and look at. It's an important vital sign, your neuro assessment. Here's an easy way to kind of remember. We're going to use this mnemonic called PFUTS, like peanuts, but PFUTS. Pupils, check pupils, eyes, movement, eyelids, have them shut their eyes and stuff. Ears, can they hear this? Facial sensation, can you feel this on this side, up on your both sides, and up on your forehead? Facial movement, can they smile? Their uvula, if they're talking and not sounding weird. The tongue, stick it out at me from side to side. Does it go from one side? Does it, jet off to the left? Have them swallow, have them bite down, and then shrug their shoulders. And this is a kind of an easy thing. I've also got handouts. I'm going to perform a cranial nerve assessment and a VAN assessment and add it to the videos here, but I needed to get this lecture out before I did that. So look for those. Here's some references, stuff that I've used in this. And this is the thing about Natasha Richardson. Just real quick, I'm not done yet. I just wanted to add that here instead of at the end. Okay, now we're gonna talk about dermatomes. And I really didn't learn a whole lot of this until I got into my paramedic class and kind of how cool it was. But at each vertebra in the neck and back, there are two nerves that branch out, and those are called spinal nerves. And those spinal nerves carry signals to and from the body. There's skin, the areas of the skin that we have sensation correspond to specific spinal nerves, and these are called dermatomes. And that's a weird word, so I thought I would tell you where that came from. Yes, the zebra. So let me help you with this. So our skin contains lots and lots of touch, vibration, position, pain, and temperature sensors to help us figure out our world. To do this, these sensors are connected to the spinal cord in much the same fashion as an electrical outlet is connected to a fuse box. In the body, the connecting wires are nerves, which are called sensory neurons. Once they enter the spinal cord, the sensory neurons run together in a bundle of nerves called a tract. That goes to the brain. So luckily for us, our sensory neurons don't grow randomly around the body all willy-nilly. Instead, they're arranged in a striped pattern, which looks very much like the stripes of a zebra. The striping pattern is known as dermatomal pattern. So that's how we get dermatome, because each stripe, and you can see things here, you know, these are all dermatomes. And see how it looks like the zebra stripes. So the neat thing about dermatomes and why we're talking about them is that they are fairly discrete, meaning there is really only one sensory neuron per dermatome. Because of this, finding a defect in sensation at a dermatome can tell us about the damage at a specific level in the spinal cord, which is super cool. So the dermatomes and nerves they give information to are both named for the portion of the spinal cord where the nerve connects. For instance, the nerve entering the spinal cord just below the T4 vertebra is called T4, and its dermatome is also called T4. So in this lecture, we're going to talk about 4 important dermatomes, which I have highlighted here. We're going to talk about C4, T4, T10, and L1, which is like right here. The C4 dermatome is pretty important. It's at the level of the clavicles and kind of makes like a necklace around the neck. So C4, level of the clavicles, those dermatomes, beginning and ending at the 4th cervical vertebra. So C4 at the level of the clavicles. T4, so we're talking about this right here. The T4 dermatome is at the nipple line. And an easy way to remember that is T4, T is for tips of the nipples. So that's just an easy one. So C4, clavicles, T4, nipple line, T10, the dermatome T10 is at the belly button or umbilicus. If you think of the 0 in T10 as looking kind of like the cute little belly button, T10 with the little cute belly button 0. That's an easy way to remember that one as well. Now the last one right here at L1 is at the inguinal line. So like if you had a Now, I would never wear an orange Speedo, but if you had a Speedo on, it would be right up, right there at that tan line. So L1 is a good way to remember a lifeguard with a tan line right there. So lifeguard 1. So why do we care? Why do we care about dermatomes? So when trauma has happened that has had a complete cord resection or transection, sorry, where it's, you know, the cord is completely severed, all sensory and motor function, except for those reflex arcs below the level of that injury, is gone. So nothing, no sensory, no motor. In these cases, dermatomes are interesting, and the ability they give you to estimate where the spinal cord is injured can help you treat and protect the ABCs. So what kind of should scare you is a neck injury here. C3, C4, C5, keep the diaphragm alive, if you've ever heard that. So that refers to your phrenic nerve comes out there. The phrenic nerves are 2 nerves, one on each side, that descend from the cervical spinal cord and innervates the diaphragm, so connects the diaphragm. It helps us breathe, helps our diaphragm contract and relax. So that helps us breathe. The roots of the phrenic nerve are in the spinal cord just above the vertebral bone, C3, C4, C5. Trauma at or near that level, C3, C4, C5, may not only damage the phrenic nerves and paralyze or partially paralyze the diaphragm, but because they lie farther down the spinal cord, the intercostal nerves that tell the rib cage to move will be damaged as well, possibly. Okay, depending on complete transection and all. Okay, so that should scare you if somebody's not breathing at all. Now we're going to talk about something else about the intercostal nerves. Okay, now, so we got the phrenic nerve that innervates up here at C3, C4, C5. So if that is transected, our phrenic nerve is not going to work so well. So intercostal muscles, the muscles in between your ribs, sorry, and the nerves that innervate that come out of the thoracic spine. So the intercostal nerves, which innervate the intercostal muscles and allow the rib cage to assist with us breathing, are associated with T1 through T12. So if these are still intact, but our phrenic nerve is not, we may still have some intercostal muscle happening, contractions happening. So we humans have 12 ribs, and each rib is connected to a thoracic vertebrae. So T1 through T12, patients that damage between T1 and T12 can lose the function of their intercostal muscles. Now, if they're damaged down here in T1 through T12, they haven't damaged up here at the phrenic nerve. So they will still retain the use of their diaphragm, which is good. So next easy step, if you remember, our dermatome is T4, correlates with the nipple line. And there's only 2 reasons why spinal cord damage in the region of T4 is worrisome. The first is the risk of losing innervation of the intercostal muscles, which we just discussed. And the second is the risk of losing innervation of the sympathetic nerves. So the sympathetic nervous system nerves, those nerves exit the spinal cord between T1 and L2. Because of this, some spinal cord damage between T1 and L2 can cause damage to the sympathetic nerves. Our sympathetic nervous function to increase our heart rate, constrict our blood vessels, dilate the bronchi. That would be gone if it was damaged. Sympathetic nerve damage keeps the body from performing these activities below the level of the injury. Severe spinal cord damage at or above T1 will stop the signaling to all the sympathetic nerves, and so can cause neurogenic shock or spinal shock, which you're going to talk about in the trauma, where all the sympathetic nervous system nerves just kind of release and you get massive vasodilation. Imagine what that will do body-wide to your blood pressure. So that would be a bad thing. Spinal shock or that neurogenic shock. Massive vasodilation that occurs causing massive hypotension. All right. So, and then we're not, because we don't have that sympathetic response from that vasodilation, our body's like, hey, I need to compensate. Well, because the sympathetic nervous system isn't working, they're not going to get tachycardic to help the blood pressure. They're not going to have increased cardiac contractility, or increased heart rate, or any of that sympathetic stuff. So that would be not good. They're not going to be pale. They're going to be red. They're going to flush, because of that vasodilation. So it doesn't look like hemorrhagic shock, where they get pale, cool, diaphoretic, because there's no sympathetic response compensation at all. Okay. So that is kind of a little bit about T1 through T12. Let's see, did I talk about L1? Yeah, no, I don't think I did. So we kind of just talked about T10-ish. So damage to the cord outer below L1 doesn't have as many systemic effects because of the sympathetic nervous system not being involved. So if they don't have feeling there in that inguinal area, that tan line area there, it's not going to be as, unstable patient, I guess, as serious. So that's just kind of a quick and easy thing on dermatomes and nerves and that sort of thing. All right. Here we go. Neurons, impulse transmission. So we have neurons, which is the nerve cell. And I have some videos about neurons and stuff in a minute. But a quick and easy explanation. Neurons are composed of 3 different parts: the cell body, the axon, and the dendrites. And you can see the cell body here, the axon, and the dendrites. Sorry, my drawing is pretty bad. The cell body contains the nucleus. The axon is the projection from the cell body that extends towards another cell, carrying signals away from the neuron. The axon is usually wrapped in a myelin sheath, and I'm going to talk to you about what that myelin sheath does in a second. It basically kind of insulates. The myelin is a substance that insulates, allows the cell to transmit its signal efficiently and consistently without shorting out or losing electricity to surrounding fluids and tissues. So something that, a disease process that messes with the myelin sheath, one of them is multiple sclerosis. And it's a disease of the immune system that attacks that myelin sheath, and then their nerve impulses are not normal. So the interaction between two neurons occurs at the junction known as the synapse. And this, if I had another picture of another neuron here, that junction right here is right there. Nerve cells don't actually come into direct contact with each other. They have that little junction there where they don't quite touch. And chemicals are what, or neurotransmitters are what connects that one cell to another. Most neurotransmitters transmit their signals across that synaptic space there to other neurons, and that's how it goes fast. So here's a little video on the myelin, a little bit. I have to get my arrow.
Welcome to 2-Minute Neuroscience, where I simplistically explain neuroscience topics in 2 minutes or less. In this installment, I will discuss myelin. Myelin is an insulating layer that surrounds the axons of neurons. Composed primarily of lipids, myelin helps to prevent action potentials, which are the electrical signals that travel along axons, from decaying due to electrical current leaking out through the axonal membrane. Myelinated axons thus conduct action potentials more quickly and efficiently than unmyelinated axons, and because of this, many neurons in the nervous system are myelinated. Myelin does not cover an axon fully. Instead, there are intermittent gaps in the myelin where the axon is exposed to extracellular space. These gaps are called nodes of Ranvier, and the sections of myelin that are adjacent to the nodes of Ranvier are called internodes. The nodes of Ranvier are rich in sodium channels, which open in response to an action potential traveling down an axon, allowing positive sodium ions to rush in. This influx of sodium ions rejuvenates the action potential and helps to prevent it from dying out as it proceeds along the axon. Because the nodes of Ranvier are not myelinated, however, the action potential slows down at each node and speeds up as it travels along the myelinated internodes. This gives the appearance that an action potential is jumping from node to node, which is known as saltatory conduction. Myelin is formed by glial cells, but the particular type of glial cell responsible for myelinating axons is different in the peripheral and central nervous systems. In the peripheral nervous system, glial cells called Schwann cells form myelin. Each Schwann cell wraps around one segment of an axon many times to form one internode. In the central nervous system, oligodendrocytes form myelin. One oligodendrocyte can produce dozens of internodes on multiple axons. Because myelin is white, myelinated axons appear white and make up what is known as the white matter of the brain. We can see the importance of myelin to healthy neural functioning when we look at diseases where myelination is disrupted. In multiple sclerosis, for example, deficiencies in myelin disrupt neuronal communication, resulting in a variety of physical and psychiatric symptoms.
Okay, that was kind of cool, huh? All right, let me go back to sharing. All right, so here is a picture of two neurons. You can see that the neurotransmitters take the electrically conducted signal from one neuron and relay it to the next neuron in that synaptic gap or cleft there. So some of the neurotransmitters that we know about: dopamine, acetylcholine, epinephrine, serotonin, norepinephrine, all those are neurotransmitters. And nerve cells respond to these signals by firing or not firing. They either move or they don't. Okay. So here's two little videos we're gonna watch together. And I'm gonna take a little break, and I suggest you do the same. Just put me on pause.
Welcome to 2-Minute Neuroscience, where I simplistically explain neuroscience topics in 2 minutes or less. In this installment, I will discuss the neuron. This is a brain. Estimates vary, but right now the best guess seems to be that our brains contain around 85 billion neurons. The neuron is a nerve cell, and it's the primary functional unit of the nervous system. This is a generic image of a neuron. Neurons actually come in all shapes and sizes, but this is the prototypical version of a neuron that you'll often see in a textbook. The structures extending from the left side of the neuron that look a little bit like tree branches are called dendrites. Dendrites are the area where neurons receive most of their information. There are receptors on dendrites that are designed to pick up signals from other neurons that come in the form of chemicals called neurotransmitters. Those signals picked up by dendrites cause electrical changes in a neuron that are interpreted in an area called the soma, or the cell body. The soma contains the nucleus, which contains the DNA, or genetic material of the cell. The soma takes all the information from the dendrites and puts it together in an area called the axon hillock. If the signal coming from the dendrites is strong enough, then a signal is sent to the next part of the neuron, which is called the axon. At this point, the signal is called an action potential. The action potential travels down the axon, which is covered with myelin, an insulatory material that helps to prevent the signal from degrading. The last step for the action potential is the axon terminals, also known as synaptic buttons. When the signal reaches the axon terminals, it can cause the release of neurotransmitter. These purple structures represent the dendrites of another neuron. When a neurotransmitter is released from axon terminals, it interacts with receptors on the dendrites of the next neuron, and then the process repeats with the next neuron.
Okay. So let me go back to that other one.
Welcome to 2-Minute Neuroscience, where I simplistically explain neuroscience topics in 2 minutes or less. In this installment, I will discuss synaptic transmission. Most communication between neurons occurs at a specialized structure called a synapse. The synapse is an area where two neurons come close enough to one another that they are able to pass chemical signals from one cell to another. The neurons are not actually connected, but are separated by a microscopically small space called the synaptic cleft. The cleft is less than 40 nanometers wide. By comparison, a human hair is about 75,000 nanometers wide. The neuron where the signal is initiated is called the presynaptic neuron, while the neuron that receives the signal is called the postsynaptic neuron. In the presynaptic neuron, there are chemical signals called neurotransmitters that are packaged into small sacs called vesicles. Each vesicle can contain thousands of neurotransmitter molecules. When the presynaptic neuron is excited by an electrical signal called an action potential, this causes the vesicles to fuse with the presynaptic membrane and release their contents into the synaptic cleft. Once they are in the synaptic cleft, neurotransmitters interact with receptors on the postsynaptic membrane. They bind to these receptors and can cause an action to occur in the postsynaptic cell as a result. This action may involve increasing the likelihood that the postsynaptic cell will become activated and fire an action potential, or decreasing it. Eventually, the neurotransmitter molecules must be cleared from the synaptic cleft. Some of them will simply drift away in a process called diffusion. In some cases, the neurotransmitter is taken back up into the presynaptic neuron in a process called reuptake. Once back inside the presynaptic neuron, the neurotransmitter can be recycled and reused. In other cases, enzymes break down the neurotransmitter within the synaptic cleft. Then the component parts of the neurotransmitter can be sent back into the presynaptic neuron to make more neurotransmitter.
All right. So that kind of explains how that works. It's pretty cool, huh? All right, I'm gonna take a break right now. When we get back, we're gonna do some more in-depth stuff on strokes and seizures and things. So stand by. Okay, let's talk about some pathophysiology and some problems with our brains and stuff. So there's a lot of disorders that can cause problems, altered level of consciousness, seizures, syncopal episodes, loss of motor control, all of those kind of things. And the brain, it is very greedy, I guess. It needs, it's a high metabolizer of glucose and oxygen. So blood flow to there is important. So it is pretty sensitive to changes in glucose and oxygen and fevers and cold as well. So temperature levels are fairly important for us to be normal. And things like, cardiac arrest from heart issues. I mean, nothing's pumping the brain to the brain. So there's no perfusion, oxygen, glucose, all that is stopped. So that's a bad thing. So when there's problems or disorders or situations, diseases, processes, sickness, anything like that, it can affect our brain. So let me find my mouse here. All right, so like I just said, a lot of things can happen to cause problems with our mentation, with our speech. We can be totally unresponsive. We could be very confused, have voluntary muscle control loss, infections, tumors, seizures, headaches, all these things. So the first thing we're going to talk about in this neurological pathology, I guess, the pathophysiology of neuro is strokes. And cerebral vascular accidents or strokes or brain attacks, whatever you want to call it, is a huge thing. Over 700,000 people each year are affected by strokes. 130,000 of those die a year. Now, direct costs like homes to take care of them or nurses or all of the equipment, all that sort of stuff. Annually, direct costs are $28.3 billion. Insurance, all of that stuff. Indirect costs like loss of work, that sort of thing, $25.6 billion. So productivity, when somebody is altered and never able to work again, I mean, that's an indirect cost loss. And what are the challenges of stroke, of folks having strokes? Number one is time is brain. Just like in a myocardial infarction, time is cardiac muscle. Well, in a brain attack or a stroke, time is neurons in our brains. So when somebody is having a problem and nobody recognizes it, or they're alone, or whatever the case is, there's low public awareness. That's improving because of the national PSAs and stuff like that for like the FAST exam. People are recognizing strokes faster, which is good. And then since time is brain tissue, prolonged transports in rural areas to a rural hospital that may or may not recognize, or they have to mobilize a flight or whatever. It just takes time, and for every minute that their brain is not being oxygenated correctly, neurons are dying. So it is a big deal. So what is it? What is it? What is this that we're talking about? So we have strokes. Cerebral vascular accidents is basically an interruption in blood flow to a part of the brain, and the brain then loses function. It's that simple. So a lot of patients who have strokes can deny or not recognize it, or don't really feel those symptoms, and they don't understand what it means. And so the longer that they prolong, the worse off their stroke can be. So don't delay. hopefully people are looking at this stuff, these PSAs about exams for strokes and all that. So as the perfusion decreases and continues to decrease and is blocked, those brain cells, those neurons start to die. And there's two parts to an infarction, just like a myocardial infarction. As those cells die, that infarcted area is the dead area. That we can't do anything about that. But then there's the collateral circulation that's kind of helping still around that dead area, kind of perfusing a little bit. That's called the penumbra. And we're trying to save that part. We can't do anything about the infarcted area, but we can try with time and interventions to help the penumbra. So maybe their deficits will be gone or non-existent. So all right, so there's, oops, why did I hit the button again? So interruption in cerebral blood flow may result from a thrombus, a cerebral embolism. So those are ischemic reasons. An embolism is something that breaks off from somewhere else and travels to the brain, and once it lodges there, it's called a stroke. Thrombus is the plaque buildup. It could rupture a little bit, just like a myocardial infarction, and cause a complete occlusion of a vessel. An arterial rupture can, malformation or some sort of weakened area, aneurysm that bursts or something, that can be a bleed, an arterial rupture. Now you can kind of see here the signs and symptoms, they go up for both of them, the ischemic and the kind of hemorrhagic. So their signs and symptoms go up, and then as time goes and hopefully treatment happens, there's not an increase in their symptoms with an ischemic stroke, where as with a hemorrhagic stroke, they just get worse and worse. So we were just talking about ischemic strokes. They're about 87% of the strokes are ischemic strokes. So there is the thrombus and the embolus. So a thrombus can, like this says, the blood vessel is blocked, so tissue distal to the blocking becomes ischemic. Atherosclerosis in the blood vessels is often the cause. So, something that grows and grows, the plaque buildup, and then it completely just occludes. That's a thrombus. Whereas an embolic stroke is something breaks off somewhere else, or there is a clot of some sort that is developed somewhere else and migrates to wherever. If it migrates to the lungs, it's called a pulmonary embolus. If it migrates to the head, to the brain, it's a stroke. So some of the signs and symptoms that you might see: loss of movement, opposite the side of the body, confusion and inability to speak. Cerebral embolism could block blood flow. Patient may experience anything from a few symptoms to complete paralysis. So there are some of the symptoms you see are very dramatic, and some of them are quite subtle, depending on the location that obstruction is. So it's pretty interesting. All right, so let's talk about hemorrhagic strokes. Obviously, you know what a hemorrhage is. Results from bleeding inside the brain tissue, or surrounding the brain. People who have poorly controlled hypertension, that is one of the biggest causes of hemorrhagic strokes. And the severity, again, depends on the location and size of the ruptured cerebral vessel. Sometimes that bleeding continues and it causes rising intracranial pressure. As you remember, the cranial vault is immovable. It doesn't move at all. So it can't expand at all. So if the contents inside, which if you recall, there's three things inside our brain or inside our cranial vault. There's our brain tissue itself, so the brain, or parenchyma, brain tissue. I can't do this with this. There is the blood vessels and everything that's in those blood vessels, right? And then there's CSF fluid. So those things, if something happens and a vessel is broken, the integrity of that vessel is lost and blood just keeps seeping out into the brain tissue. It doesn't have far until nothing can move anymore and stuff starts to leak out. And CSF fluid leaks out, sometimes the blood leaks out, and if that intracranial pressure continues, actually brain tissue can leak out that foramen magnum. And if we can stop that process, maybe they can get to a surgeon and they can get help. Hemorrhagic strokes are often fatal. Symptoms, usually sudden severe onset of headache or loss of consciousness. I see that quite frequently. And that intracranial pressure keeps rising and rising. And as that happens in that cranial vault, something has to give. And if it doesn't, then we get brain herniation, and that brain tissue will herniate right out of that foramen magnum, and that is never a good thing. And this is just kind of showing you some stuff going on here. We've got, oh, I was going to tell you about cerebral perfusion pressure and what that means. So let me get this pen. So ICP, we're talking about ICP and cerebral perfusion pressure. So that's the pressure inside our cranial vault there. Is our mean arterial pressure minus our ICP. So intracranial pressure is important, and so is our blood pressure, our MAP. And our ICP is usually between 5 and 15 millimeters of mercury, whereas our MAPs, are 65 to 80-ish and more. And so this isn't a big number when it changes. It's not a huge number that changes. So most of the cerebral perfusion pressure is directly correlated to our mean arterial pressure, because as that changes, it changes more drastically. So it's important, and you will see why in a while. Okay. So this is a picture of abnormal intracranial pressures. We have normal here. See this shift right here where it's kind of doing that thing. So brain volume increases. Maybe there's a tumor growing here or something. Blood and CSF is compressed and intracranial pressure increases. This is a blood volume increases like a hematoma. This is a epidural hematoma here. Brain and CSF is compressed and intracranial pressure rises. So that's pretty dramatic pictures right there. Really quickly, what is a TIA? A TIA, or transient ischemic attack, is when stroke symptoms go away on their own in less than 24 hours. And sometimes that happens without any interventions at all. And our bodies are amazing, and they will sometimes lyse or break up those clots all by themselves. Lots of people think TIAs are fairly benign, but they're not. I think 40% of those that have TIAs are going to have a stroke within a few weeks. That might be a little elevated, but it's fairly significant, where they need to go in and be evaluated, especially if it's their first one, and then identify the cause of those TIAs and maybe start some long-term treatment so they don't have a full stroke. That would be better. Okay. So the TIA usually isn't in and of itself a dire emergency, but they can look full-fledged stroke, have looking like a really serious, very dramatic stroke, and then, minutes later, everything resolves and they're totally not looking like a stroke. So it's fairly weird. So signs and symptoms of strokes that you're going to see. We're going to see possibly some facial drooping, where one side of their face is looks like it's kind of melting a little bit. They might have some sudden weakness or numbness in one of their arms and legs. Decrease or absent movement and sensation in one side of their body is another one. Ataxia, that is kind of just stumbling when they walk. Sudden vision loss, those things could be signs of stroke. We can have dysphagia. Dysphagia is difficulty speaking, decreased loss of a level of responsiveness. Aphasia, inability to speak or make, sentences that actually work, like I'm having a struggle with. Slurred speech, sudden and severe headache, confusion, dizziness. All these things could be signs of strokes. And then you have your seizure, coma, death. Their tongue could deviate, could be combative, very confused. All these symptoms can cause or be a cause of stroke. All right, so this is just real quick. Usually our left hemisphere problems can cause, our speech centers are usually on the left parietal area, so can cause problems with speech problems or inability to produce or understand what you're saying. They could, you could ask them to make a fist and they just don't understand what you're asking them. That's receptive aphasia. And expressive aphasia will be like you ask them to repeat, it's always sunny in Cincinnati, and they are like, the dog fell, or something that's totally unrelated. Or they're trying really hard to copy that, what you asked them, and they just cannot do it. And then usually a left-sided hemispheric stroke will cause paralysis on the right side. So right hemisphere, in that, our brains are halved kind of. So we're gonna see paralysis on the left side. And then words usually they can understand language and be able to speak, but they are slurred. And this is called dysarthria, be having slurred speech. And then a right-sided stroke also is very interesting. Can cause neglect. So they'll like just neglect their whole left side. They don't even know it's there. And you'll ask them to raise their left hand or look at you, and their totally eyes are deviated. Their whole head is deviated over away from you, and they're like, I am looking at you, and they're not. So that is interesting, an interesting thing. And then the bleeding, the hemorrhagic stroke we can have with hypertension and intracerebral hemorrhage. Sometimes most of the time in the field, we can't tell what it is, whether it's a bleed or an ischemic stroke, but it doesn't really matter because we need to get them where they need to go quickly. All right, so what are we gonna do? We're going to always manage our ABCs. Remember that they could have problems with their airway, be unable to swallow, have a flaccid tongue, not be able to protect their airway. So sometimes we have to put in an OPA or NPA and bag them. We're going to give supplemental oxygen if their SpO2 is less than 94. We're going to perform a pre-hospital stroke scale, which around here is a Cincinnati stroke scale. So we have them, let me see if I can do this here. Start video. Where is it? And I don't see me, so I can't really. I don't know where I was, so I can't do that. But anyways, when I shared my screen, I told it not to do video. But we'll have them close their eyes, hold their arms out right straight in front of them, and palms are up, and have them hold for 10 seconds. And sometimes you see very minute small drop or weakness on a side. Sometimes they can't even get that arm up at all, or it just falls down. So there are degrees, I guess, of weakness. So we're going to do that for Cincinnati. So arms, we're going to have them smile or show me your teeth and see if you have one side of their face not going up. And then speaking, we'll have them repeat a sentence like it's always sunny in Cincinnati, or you can't teach an old dog new tricks, and see if they can say those words. That's a pretty quick Cincinnati stroke scale. And then we're going to go into a VAN assessment in a minute, which if they have arm weakness, then we will perform a VAN assessment, vision, aphasia, and neglect. And this is so that we can identify these large vessel occlusions. These folks need to be triaged rapidly to a place that has interventional radiology so they can have an endovascular or neuro intervention that can hopefully get that clot out of their brain. So we're going to do a pre-hospital stroke scale. We're going to check that VAN assessment if they have the arm drift. We're going to figure out when their last known well was. That is super, super important, that last known well, because time from onset of last known well is the whole basis of where I transport them to. I'm going to get the phone number of the person who saw them last known well and who can describe these symptoms, hopefully, to the doctor. So cell phone number, I'm going to get a blood glucose, get their past medical history, their medications, and I'm just going to bring them with me. I don't have to take the time to write them down, get their allergies, and did they fall? Did they have a syncopal event at all? Is there been any recent trauma? And I'm going to get a blood glucose, and any blood glucose less than 60 milligrams per deciliter, we're going to treat with IV D10, just because stroke symptoms can be mimicked by hypoglycemia. So this is important. This on-scene assessment and interventions, and we're going to get our transport time in less than 10 minutes. That's our goal, is move and groove, do everything en route, and go as fast as you can to the hospital. Okay. Our transport decision. So again, this last known well is super important. And if they went to bed well and woke up, they went to bed at 10, woke up at 6 o'clock and had stroke-like symptoms, if nobody saw them at all during the middle of the night, then their last known well is 10 o'clock at night. It's not when they woke up. So that's a bummer for them. So if the patient's last known well is less than 4.5 hours of onset, then we are going to take them to the nearest hospital that has CT imaging and can provide IV TPA. So if it's an ischemic stroke, and if it is a hemorrhagic stroke, they're most likely going to decide whether it's an emergent transfer or what they need to do to get that person to the right facility. So last known well, less than 4.5 hours, transport to nearest hospital with CT capabilities and can give TPA. If it's greater than 4.5 hours, especially if they're VAN positive, we're going to transport to a level 1 stroke center here in the Treasure Valley. That would be St. Luke's Regional and St. Al's Regional are the level 1 stroke centers, comprehensive stroke centers, meaning they have neuro interventional radiology, and they're going to be able to get in there if it's if they're able to, and get that clot out. We'll talk more about that in a minute. En route, as soon as we can, we're going to notify the receiving facility that we're coming in with a brain attack or a code stroke. We're going to give them as much time as we can so that they can empty the CT room if they need to, kind of swap around patients if they need to, and then hopefully we can go pretty much almost straight to the CT scan. Last known well is very important. Their past medical history. If I did a Cincinnati stroke scale and they had arm weakness, I'm going to tell them if they're VAN positive. So when I go to give my report, I'm going to say, I am bringing you a code stroke, last known well for this 70-year-old female was, at whatever time it is, 10 a.m. That's, 2 hours ago. They have a past medical history of something very quick. They are Cincinnati stroke positive with arm drift, VAN positive with left side neglect, or whatever the case is. They do take anticoagulants, and when I get there, I'm going to give them the phone number of the witness and the meds. Okay, so very, very important stuff you need to give them. Last known well is this: Cincinnati stroke scale positive, VAN positive, vitals are this. We'll be there in 10 minutes. I'll give you a better report. Glucose was, 82, because they need to know that. So we do a glucose before we even kind of load up sometimes and just go after it's normal. Treatment guidelines, time is brain again. So ABCs, this is just to reiterate what we just talked about. En route, again, we're going to perform these things always. En route, we're going to get a 12 lead and a 4 lead EKG, continuous monitoring. We're going to treat that blood glucose if it's low or whatever. And we're not going to give anything orally because they might have a problem swallowing. And then we're going to get at least one large IV, at least an 18 gauge in the right AC. 2 is preferred, so we try to get 2 large bores in the patient. Again, stay within your scope. If your scope does not include IVs, then you're not going to do it. All right, so now I'm going to talk to you about large vessel occlusion. And we're going to watch some videos about it. Okay, so here are 2 videos we're going to watch and kind of introduce us to this large vessel occlusion in the VAN assessment.
I've been using VAN for about 5 months now. I think it works really well. We've identified multiple patients just by using the VAN score that had large vessel strokes, which we wouldn't have picked up on an NIH stroke scale that we normally would use. One of the patients had an NIH stroke scale of 4, and I think the other one was around a 6. I can't remember the exact number, but both of them had large vessel occlusions. One had a large dominant MCA occlusion, and the other one had one on the right MCA. One we ended up using the VAN score, ended up taking him actually to IR and treating him with a thrombectomy, and he did great. And then the other one we just treated conservatively with IV fluids. It broke up the clot, so he didn't need to really go to endovascular, but we wouldn't have identified these patients that were having large vessel occlusions without using the VAN score, given that the NIH stroke scales were low.
So when Dr. Taleb first described to me the VAN protocol, and especially after I read the initial research, I was overwhelmed and just overcome with joy, because being able to localize a patient's symptoms to a vessel and then triage them to endovascular treatment is huge in the world of stroke.
So Stroke VAN, it's an incredibly easy screening tool to use, and what it does is identify large vessel occlusions. So when you have a patient who comes in and the patient is VAN negative, I know right there that the patient probably will respond well to IV TPA. Now, if the patient is VAN positive, then I know I have to triage these patients a little bit differently.
It's actually quite easy to use. You really are looking for 4 main symptoms. You're looking to see if they have weakness, whether they have vision loss, whether they have neglect or aphasia.
So when VAN came along, and we can now, with a very simple, easy to remember tool that is valid no matter who applies it, and we're talking whether it's a physician, a nurse practitioner, a PA, a nurse, a paramedic, EMT, and ultimately my hope is folks at home. We will be able to very quickly triage these patients to the level of care that they require, and that's going to be the most effective for them.
So when you're looking at outcomes with a stroke screening tool like VAN, it's what separates VAN, I think, from some other large vessel occlusion scales that are out there, is that it's so simple to perform. And it was truly written for the first responders. That's what was developed for. When I respond to a stroke alert and the nurse tells me the patient is VAN negative or VAN positive, it helps me to triage these patients quicker. This scale was not developed for a highly trained stroke neurologist. It truly was to help nurses, emergency room physicians, EMS, to better triage these patients so they can get the acute care that they need.
So the reason I like VAN as opposed to other scales that have been validated, is that one, VAN is very easy. It's positive or negative. It's a switch. It's on off. It's yes or no. There's no addition. There's no, trying to put the score on a scale and then look at different research. It's yes or no. The VAN looks at something that other scales don't look at, which is specifically the posterior circulation. So we capture strokes that would ordinarily be missed.
And it kind of streamlines your triage process to where you can kind of figure out, okay, which ones are large vessels, which ones are small lacunar strokes that, treatment can be a little bit different. We can identify which ones need thrombectomy pretty quickly using either a CT angiogram or an MR angiogram, and decide where they need to go, if they need to go to thrombectomy versus, just treating them conservatively depending on what we find.
How I use VAN as a triage tool is when that patient is VAN positive, I do the vessel imaging, but I also contact our neurointerventionalist to look at that CTA to do an immediate read and see if that clot is proximal enough that we can use endovascular interventions to remove that clot and to improve outcomes. And I don't think you can really truly appreciate what a tool like VAN does until you're actually in one of those stroke alerts where a patient comes in with devastating signs of a stroke and you have two treatment options to offer them, IV TPA and or thrombectomy. So when you see a patient who comes in with severe stroke symptoms and we triage that patient to neuro IR, they get a thrombectomy performed and they're back to an NIH stroke scale of 0, so to baseline. That is huge in terms of outcomes for that patient, and it's huge in terms of quality of life. This patient is not going to go to a nursing facility, with severely disabling deficits for the rest of their life. This patient is going to go home and have a good quality of life. So when you truly see those before and after, because of something as simple as using a screening tool that can easily be done in 60 seconds or less, if the patient doesn't have any weakness, then you're done. You move on, and you know that likely that's a small vessel occlusion, and TPA is going to work well for them.
Stroke is devastating. It's, I think, an annual cost in this country of somewhere around $34 billion, which pales in comparison to the human cost. It's the fourth leading cause of death and the leading cause of adult disability in the United States. So having the ability to localize someone's stroke to a large vessel using a simple mnemonic tool and then go in endovascularly and essentially cure them of their problem. And this is the closest thing we have to stroke away that's ever been invented.
Okay. Got that one. Oh, watch the second one. Might do that one.
Hello, and welcome to VAN training. What we're going to do today is just go over a basic VAN exam. You'll also have the PowerPoint going through the different steps. So step 1 in the VAN is you basically just ask a person to hold up both arms like this, with palms up for 10 seconds. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Very good. So that's the number 1 thing. And that is the essence. If they have no weakness, there's no drift at all, there's no weakness where it comes all the way down, or if they're not flaccid, then you don't have to finish the rest of the exam. They're VAN negative. If they do have any weakness, whether it's a slight weakness, full weakness, or they completely come down, then you test vision. So what we do is we test 4 quadrants. Please look at my nose. How many fingers do you see? 1. How about now? How about now? How about now? 1. And that's testing the 4 visual fields. You see, you have them look at your nose and you basically test the 4 different areas. Right upper quadrant, right lower quadrant, left upper quadrant, left lower quadrant. And then you just have to look over, make sure their eyes are even. You're looking for uneven eyes. And do you have any double vision? Okay. And then the next thing, so that's vision. The next thing you test for aphasia. Aphasia is 3 different things. Naming, what's this? What's this? That's 2 objects, and then repeat after me. Today is a sunny day. And then after that, you have them follow 2 commands. Close your eyes, open, make a fist, open, and you're done with the aphasia part. If they're positive in the aphasia, they either can't name objects, or they can't repeat, or they can't follow commands, then they're positive for aphasia. And the last thing is neglect. For neglect, you just look at them, make sure that their eyes aren't forced all the way to the right or left. If they have forced gaze, look at my eyes. Their eyes are forced all the way over like this. They're not looking towards the right. Yeah, I'm looking at you, and they're looking towards the left, or vice. Yeah, I'm fine. I'm fine. There's nothing wrong. My eyes are all the way over. So you make sure. And then the other test is you close your eyes. Tell me which side am I touching? Which side? Which side? If they have neglect, they'll tell you only right or only left when you're touching both. So you do right, left, and both. And that is the entire VAN exam. Please feel free to contact us if you have any questions. How you score the exam. If they're positive with anything in the vision, aphasia, or neglect, plus weakness, they're VAN positive. If they have no weakness, they're VAN negative. If they have weakness, but the vision is normal, the aphasia is normal, and the neglect exams are normal, they're also VAN negative. Thank you so much, and we look forward to identifying massive strokes early in the field.
Okay. So, all right, large vessel occlusion. Why are we doing this VAN exam? So like they were saying in that video, a large vessel occlusion absolutely needs to be triaged and taken to a comprehensive stroke center or a level 1 stroke center is what they call it here, with neuroendovascular lab for life-saving procedures. They have to be, that thrombectomy, if it can be done, needs to be done quickly, within 24 hours. The TPA is only given in certain circumstances under the first 4.5 hours. In one of the studies that this doctor did that was speaking to you in that video, I can't remember, I think it was in Phoenix, Arizona, but before the VAN testing class went on or education went on, their ED door to TPA was about 56 minutes, and transfer to surgical interventions was about 110 minutes when they walked in. Now with the VAN training and being able to triage that in a more timely manner, the average time to TPA is 35 minutes and interventions 91 minutes. And if you recall, that time is brain, and they've even gotten faster since he published. So that's kind of cool. It's getting even better, and it's getting better here as well. If anyone's ever taken someone to neuro IR, it's amazing what they do. So an assessment tool, that's what the VAN assessment is a large vessel assessment tool. It's, like they said, helps triage the patients to a hospital that can help with that thrombectomy to get that out. And then it's very easy to perform. We have the vision test, the aphasia test, and the neglect. So VAN. It's awesome. It's easy to remember. So we're going to kind of go over it again. I know you just watched the doctor do it. So in the vision, first off, before we get to the VAN assessment, if they don't have arm weakness at all, we don't do the VAN assessment. So if they have arm weakness, then we get to do the VAN assessment. So first thing is the vision. So I'm going to ask them if they are seeing double or if they have any blindness that's new. Then I'm going to do a field cut. And you saw him do 4. You know, he held up his fingers out in 4 areas. You only have to do it on the right side and the left side. You don't have to do it upper and lower anymore. They found that if it's a positive sign, that they're going to have it in just half of it, not, you don't have to do all 4 quadrants. So field cut, hold up 1 or 2 fingers on both sides of them, have them look at your face, and then hold up those fingers. And then is their gaze to one side? So vision, double vision, do the field cut, and is their gaze different? Okay. Then aphasia part, have them name 2 objects. So point to your watch or pull your pen and your phone out, doesn't matter. Just say, what is this? And hold up your pen. What is this? And they say a watch because you're pointing to your watch. That's expressive aphasia if they cannot name it. Receptive aphasia is not understanding or following what you ask them. So have them do 2 things. Close your eyes and then make a fist. And if they do those things, they don't have receptive aphasia. So that's expressive and receptive. And then the N, the neglect. So if they have a forced gaze to one side, they basically are unable to feel their arm when you touch both of them. They don't have any clue that you're touching one side. That is neglect. They're ignoring one side, they're looking over to the other side. And then just so you know, you can become a VAN certified person who takes a class, and that just says you understand, and it's free. So if you go to strokevan.com, you can sign up for free education. Also, train.org/Idaho has an Idaho TSE, which is time-sensitive emergencies stroke education for EMS. And I just did this not long ago when I first started this training, just because I do it every time I do this training. So you can get that education as well. So train.org/Idaho/welcome is where you're going to go. All right, now I said something about comprehensive or level 1 stroke centers. So a facility that has the ability to have the thrombus sucked out or neurointravascular procedures is a level 1 or a comprehensive stroke center. Here in the Treasure Valley, we have St. Al's Regional and we have St. Luke's Regional. So if someone has arm weakness and VAN positive, that's where we're going. Okay, and I'm going to show you the protocols in a minute. All right, now level 2, which are primary stroke centers. This is St. Luke's Meridian Medical Center is, and what that means is their primary stroke care. They have possibly mechanical thrombectomies, but only at certain times. So St. Luke's and St. Al's may have them 24/7. These may or may not have mechanical thrombectomies. And a level 3 center is West Valley Medical Center and St. Al's Nampa off of Garrity. Those folks can stabilize, do the CT, give TPA, and make an emergency transfer out of there to either St. Luke's or St. Al's region. So that's what that means. All right, so we've talked a little bit about strokes. We've talked a little bit about van assessments and large vessel occlusions. Let's look at things that are in our differentials if somebody is altered, and things that can mimic stroke-like symptoms. So hypoglycemia or low blood sugar, a postictal state from having a seizure, generalized seizure, subdural or epidural bleeds can mimic a stroke with the symptoms. So let's talk about that. The subdural and epidural bleeds usually occur because of a fall or a trauma or a smack in the head or something like that. With the bleeding, the subdural or epidural bleeding, the onset of stroke-like symptoms and signs may be very subtle. It's not like half their faces drooping off. It might be that they just can't feel one-sided, one arm or something like that. And we will talk more about subdural and epidural bleeds in your trauma module. Oops, went the wrong way. Okay, 2 of 2, okay. So those were some stroke mimics. Now let's kind of talk about seizures for a minute and what seizures are. So seizures are basically a bunch of neurons just firing like a storm happening, very sudden. They have usually some signs and symptoms that are sometimes easy to figure out. Sometimes it's harder to figure out that they're having a stroke. And a seizure can be a generalized seizure where they're doing the floppy fish thing on the ground, to just one hand shaking, to just their eyes bouncing, deviating off to the left, or lip smacking. So there's a lot of different presentations of strokes. I mean seizures, I'm sorry. I'm not talking about strokes now. Seizures. So we have some types of seizures or classifications of seizures. Generalized seizures or partial. These are the kind of the 2 types of seizures that there are: generalized and partial. So let's first look at the generalized seizure. This is formerly what we used to call the grand mal seizure. So tonic-clonic jerking, full body jerking movements. That's what the generalized tonic-clonic type seizure is. Now, the generalized absence seizure we used to call a petit mal seizure, and it's basically when they just all of a sudden just freeze and stare. Could be just a few seconds, it could be a little bit longer, but they're just kind of absent for a minute. So those are the petit mal seizures. And then we have pseudo seizures, which are actually called psychogenic non-epileptic seizures. And we're going to talk a lot more about those, because I'm really tired of people just saying, well, it's not a true seizure, they're faking it, and that's a pseudo seizure. That's not what psychogenic non-epileptic seizures are. They're actually caused by a psychiatric condition, and if that finally is figured out, once they deal with those issues, usually their symptoms go away, but they can look like they're having a complete huge seizure. That's a generalized tonic-clonic type seizure. Again, these people are not faking it. They are not trying to fool you. There are people out there for some reason that do try to fake seizures, and I don't understand it, but you're going to do a paper on this, so I need you guys to write this down. Psychogenic, non-epileptic seizures. Oops. Oh boy. Okay, so that's a generalized type seizure. Those are the types of generalized seizures. We have the tonic-clonic, the absence, and the psychogenic non-epileptic seizure. Then there's the partial seizures, and we have simple partial seizures and complex partial seizures. Simple partial seizures can be shaking of one area of the body. It can be sensation in one area of the body. It's just one focal area that is having that neuronal electric storm. A complex partial seizure will be some very minute changes in level of consciousness. They could just suddenly stare out into space for a second. Not like a petit mal seizure, but they just stop. So they'll be maybe walking or something, they'll just stop. And it could be that they're confused, they have hallucinations, they're just not able to speak. Could be that their eyes or hand or head just starts to make these very small movements. And once it's over, they just carry on. Sometimes they get rather combative and angry. So a lot of times you just kind of stay out of their way until it's over with. So complex partial seizures. So some causes, abscess in the brain, alcohol or alcoholism, birth anomaly, maybe in the brain infections like meningitis and encephalitis, trauma to the brain, maybe the scarring, or it's an acute thing and they suddenly have a brain injury and have seizures. Diabetes can cause seizures, a rapid rise in their fever, eclampsia from some pregnancy-induced hypertension that can cause seizures, and when it causes seizures, it's called eclampsia. Idiopathic, or they just don't know why you have seizures. So maybe the medications that they're taking, maybe they took too much, maybe it was overdosed accidentally or unintentionally, whatever. Organic brain syndromes, things like Parkinson's, Alzheimer's, recreational drug use, strokes, TIAs, sepsis, systemic infections, tumors, and kidney failure, because our kidneys kind of filter out everything in our body. So if those are failing, we're going to have toxins build up. Okay. Let's see. Epilepsy is kind of almost a propensity to have epilepsy. Okay, I think I've said all I need to say on that one. So now we have the importance of recognizing seizures. Recognize when a seizure is occurring or has occurred, and whether this episode differs from previous ones. So if somebody saw it, it's much easier to do that if you have a witness to ask questions. It's very important to try to find that, what happened. So sometimes you have a patient that's fairly unresponsive and you're trying to figure out why. So recognizing a postictal state, that they could be, gagging on their blood in their mouth or not able to swallow, and they could have an airway problem, those kind of things. During the seizure, that usually, especially if it's a generalized seizure, they're usually not breathing through that, so they get rather hypoxic and their brain gets hypoxic. They could get cyanotic and have some hypoxia, confusion, and all that. If they fell during that seizure or before that seizure, do they have trauma related to that? Because a lot of people do. And then wait, what just happened? And then looking at other problems like if they're incontinent, if they bit their tongue during that seizure, those are very important things to recognize. Sorry, I turned that too fast. Okay, so let's talk about the postictal state. So once the seizure stops, especially if it's generalized tonic-clonic type seizure, the patient's muscles relax. They become rather limp, and they're sweaty because they've just kind of run a marathon in a matter of 30 seconds is what they say it feels like. They're tired. They're in a hypermetabolic state. They're breathing hard, hot, sweaty, all that. Probably sometimes they're incontinent. Sometimes they bit their tongue. And sometimes that postictal state can cause hemiparesis, where they can't move or they're weak or tingly on one side, kind of resembling a stroke. The most common characteristic of a postictal state is the lethargy and the confusion. So they're tired, they're altered, they're confused, they can get combative rather quickly. And orienting them to what happened is really important. And trying to figure out if this is a seizure that they have history of seizures, or is this a seizure because they have something new going on, or check their blood sugar, see if they're hypoglycemic, see if they have a fever, they're septic, or something is going on that's out of ordinary. All right, so let's take a little break. If you feel like it, I'm going to stop this for a minute. Okay, I hope you had a good break. We're going to go into altered mental status. And there's a lot of causes of altered mental status. Patient who is not thinking clearly or who is not capable of being aroused is altered. This is the most common neurological emergency next to strokes and seizures, is altered mental status. And this is, again, when they aren't thinking clearly, they're confused, they're not capable of being aroused, and they're unresponsive. So. Okay, so like we said, in your textbook, what did I say, 686 for the basics and 862 for the advanced. We've got the causes of altered mental status, AEIOU tips. It's a great thing to memorize. That mnemonic has helped me kind of think through differentials on many calls. So, and we're going to try to make sure that we don't miss something that we can fix. Like we didn't check a blood sugar, we get to the hospital, they're still altered and they're hypoglycemic, they give them something and they walk out of the hospital. So that was all that was wrong. So we're going to hypoglycemia, hypoxemia, intoxication, drug overdose, head injuries, former or acute, brain infections, encephalitis, meningitis, body temperature abnormalities. So we've got alcohol and acidosis and epilepsy and endocrine problems like thyroid conditions or any metabolism problems, electrolyte problems. So maybe their potassium or sodiums levels get off. Insulin problems, so diabetes, opiates or other drugs, uremia, kidney failure, trauma, temperature changes, infections, poisoning, psychogenic causes, shock, stroke, syncope, space-occupying lesions, and subarachnoid hemorrhages. So those are some causes of altered mental status, which is kind of here. And if we find something that we can fix, we fix it. Syncope or fainting, a sudden and temporary loss of consciousness. They have a loss of postural tone and kind of fall down. And hopefully they didn't smack their head or something, but if they did, we need to tell them they need to get evaluated and figure out what's wrong, because it could be something as benign as just a vasovagal episode where their vasculature just kind of opens up, and their heart rate might go down at the same time, so they have a change in perfusion and blood supply to their brain, and they have a syncopal episode. Some causes that are more severe and problematic are cardiac dysrhythmias and conduction problems. Maybe they had a myocardial infarction and their heart is not pumping at all, hardly. Myocardial infarction, dehydration, or electrolyte imbalance, hypoglycemia. All those things can cause a syncopal episode. Hypoxia, which I don't see on here. And this lecture is going to get faster and faster now because we're down to the easy parts. So now let's talk about headaches. We don't usually get called for a headache. It might be a symptom of something bigger though. So tension headaches, migraines, and cluster headaches. They could have tension headache caused by muscle contractions of the neck and the head and the back attributed to stress. Not a big deal. People don't call for that. Migraine headaches sometimes. They're really bad. If you've ever seen someone actually have a migraine, they're very, very unpleasant. They're photosensitive, so any light, any sounds. It's thought to be caused by changes in their blood vessel size at the base of their brain. They may have things like an aura, like some generalized seizures can have an aura where they can smell something or taste something or something like that before it starts. Patient often describes the pain as throbbing, pounding, or pulsating. They're usually nauseous, they're vomiting, they can't hardly open their eyes because it hurts so bad. They want to be in the dark, and it can last for days, which I don't think is very nice. Okay, cluster headaches. They're vascular headaches. They occur in groups or clusters. They may recur for days and then stop. Usually minor pain around an eye, it intensifies, it spreads. It's anxious, causing, anxiety, and could or could not go away. And then last, sinus headaches. We don't really care much about sinus headaches. Inflammation in the sinus cavities, infection within there can cause pain in the superior part of the face. If they bend forward, it gets worse. All right, so let's talk about our assessment. And this is where we're just gonna kind of move quickly now, because we've talked about assessing, we've talked about interventions as we've gone. We're just kind of trying to make sure that you've connected those dots now. So we understand that the brain is very sensitive to low perfusion states, low oxygen, low glucose, high temperatures, that sort of thing. And it responds by going wacky woo. So, look for stuff, look for subtle changes, look for how they're talking to you or walking or anything like that. We always take standard precaution procedures, especially now at the COVID environment. Look for clues in your general impression around the scene. Get your head on a swivel is what I call it, and look around. Don't walk into something that's not safe. Ask them about what happened. If they're unable to tell you because they don't know, you're going to need to ask anyone that maybe saw what happened. If they're confused and you don't know what happened, you're going to have to assume that you need to take spinal precautions and make sure they don't move around and make something worse. You know, once you get kind of a general impression and perform your primary assessment, you're probably able to make that transport decision. Is this a stroke? Do we need to call for air medical support? If our primary stroke center is far away, do we take them to the nearest facility for the CT and the TPA interventions? All that stuff has to be kind of thought of early. Okay, so we're going down in our scene a size up, and we've considered that, all those issues. Now we're on our primary survey. Is done the same way on every single patient. Form your general impression, check their level of consciousness, if they're altered, see if anyone's there to answer questions for you. Look how they're if they're posturing. This is showing you a decorticate posturing. You can see this one right here where she's drawn her arms, flexing her arms in. They usually extend their feet out as well. And the decerebrate, you can see their arms are extended outward. So core, decorticate to your core. Decerebrate would be posturing with their hands and feet extended. Are they doing that? And that's kind of in your general impression. And then focus on the airway and breathing. Can they maintain their airway? Is it clear, open, and patent? Suction if it's not. Provide ventilatory support if you need to, if they are not breathing on their own. Check their breathing. Do we need to add oxygen, supplemental oxygen to that? Their circulation, do they have radial pulses? If not, check a carotid pulse, and if they don't, start CPR. Check to see if there's any bleeding around, and check to see their skin signs. What do their skin signs look like? Are they pale, cool, and clammy? Are they flush and hot? So we've got to figure out all of that. Okay. So what's our transport decision? Are you having a stroke? Let's do a quick Cincinnati stroke scale. If they have arm weakness, we are going to do a VAN assessment. We're going to decide what transport decision we have and move. If it's a stroke, we're going to be moving quickly. Unstable patients, we've got to transport pretty quickly and then try to stabilize them, at least their airway, breathing, circulation, and route. So now there's people that can ask questions while you're doing your primary assessment. That's awesome. It's easier to kind of do it that way sometimes, where the firefighters will get a past medical history and their medications and allergies while you're doing a stroke assessment. And that's a great thing. But history taking while we're en route, or while we're trying to figure out what's going on. Was this a seizure? Is this a sugar problem? You know, are they been drinking? Did they fall and hit their head? Have they been doing any drugs or something like that? So investigate that chief complaint. Ask questions. Obtain a history from the people around if you can. If the patient's unresponsive, try to get somebody around, bystanders, family, anything that saw them. As they're answering your questions, evaluate their speech, looking for trauma, get a sample history, including meds, allergies, past medical history. When it's time to do a secondary assessment, we are going to do a complete secondary assessment. And figure out what's going on, or if we missed anything. We can do a cranial nerve assessment as part of our neuro assessment. Assess for injuries that we might have missed. Look at their tongue, you know, see if they bit it, or we call that tongue abrasions. So we've talked a lot about rapid identification of strokes. We've talked about the Cincinnati stroke scale. First, if there's arm weakness, then we're going to do a VAN assessment. We're going to transport decision based on stroke findings. Our reassessment survey, again, for unstable patients every 5 minutes, for stable patients every 15. We're going to basically repeat our primary survey. So let's look at our airway, breathing, circulation again. Let's look if their level of consciousness has gotten better or worse. Let's retake their vitals, and let's see if any of our interventions have helped, or anything has gotten worse. That's why we reassess. Routine monitoring, heart rate, blood pressure, respiratory rate and pattern, pulse oximetry, and glucose for sure. And we're so awesome, we're going to do a cranial nerve assessment as well. Yes, we are. And of course, Glasgow comas. If they're confused and if it starts to get better, we're going to note that. Emotional support. So at the end of this, I have a video. It's two videos. It's in two parts. It's a really poor video of a show. If you remember, I don't know, 12 years ago or something, the show called ER kind of started all this show stuff. But it was this actually, I remember this this episode pretty vividly, and it changed how I talk to people who are altered, having strokes, kind of unresponsive, all that sort of stuff. So that emotional support is super important. Early in your career, I made the mistakes of thinking that, you know, I knew more than I did and that I was the boss. Well, I quickly found out that patients don't read my textbooks, and sometimes they present it in ways that I can figure out what was going on. So it's humbling, and I try very hard to be humble and to help my patient. If that means sitting and letting them chat at me, and that is what they need for me to hold their hand or pat their arm or rub their, you know, arm. There's times when I don't social distance, okay? Early on notification, so that the facility can get ready for you, is great. And then documentation and all the things that you did and intervened with and all that is important. Okay. This is a bad recording, but I wanted to show you from a patient's point of view and identify things that they did well, identify things that they could have done better. Okay, so this is long, and then I'll start the other one, and it's the ending of it. So just sit back, and it's a horrible recording, but we're gonna try it. Okay, let me get my arrow. Okay, here we go.
Can you, sir? Sir? Hello, doctor. I don't know. I got a little dizzy. I mean, I had too much coffee or maybe some kind of anxiety attack. I am perceiving you know, my dad actually has high blood pressure. I don't.
Can you tell us your name?
Yes, Ellie.
Sorry?
My name is Ellie Shore. It's kind of bright in my eyes. There's nothing wrong with my eyes. Nobody is listening to me here. Monitor. Am I slurring? Is there something wrong with my tongue? It does feel kind of numb. Maybe I'm not talking loud enough. It's 96. So normal rhythm. Excuse me. Where am I?
Ma'am, you're at a county hospital. We're going to take care of you, okay?
County? Great. You squeeze my hand? Yeah. Look, I don't know what that paramedic guy told you, but honestly, I'm fine. So you could just stop doing all this, okay? Let me up and call me a cab, and I'll be on my way.
Now squeeze with your right.
What did you just do?
As hard as you can. Squeeze.
I can't. Is that my arm? Because I didn't feel it. I didn't feel anything. What's wrong with my arm? What's wrong with my arm? Oh God, where's my leg, my foot? Why can't I feel my Whoa. Miss, what do you do? Wait, when you circle my pants? Miss, please. Not my underwear. I'm not trying to relax, okay? Now I'm gonna put a catheter into your bladder. Might be some discomfort as it passes, okay? My lips are moving, but nothing's coming out. I don't feel sick. I don't
No carotid
feel
bruise.
anything. Well, I feel something. What do you think it is? Bad. Onset of symptoms is too quick for I'm healthy. I have 3 kids. I'm 35.
Could be a hyperglandular
The
state.
kids. Oh my God. The kids. Oh God. The kids.
Have a name on her yet?
Yeah. I've got to No. Just wait a minute. I have to tell you something. Somebody's got to pick up my kids. No one's picked them up. You have to call my husband and have him do it. Anything symbolic?
You know, more than likely.
Okay.
Please?
Please? I think she wants to write something.
Go ahead and let it through.
So, maybe I could reverse it.
Yeah, there's no breathing. It could have been done 3 hours, but no emotions down. Ellie? Can you hear me?
Yes, I can hear you. His name is Dan. This is
We
his
think
cell
you
phone
might have had a
number.
stroke.
Tell him he needs to
Found it
take
makes
the
it
kids
impossible
because
for you
I'm
to
in the
express any
hospital.
language. So while you might be able to understand us, we definitely won't be able to understand you.
That's not what I wrote. What did you do with what I wrote? Okay, that's not what I wrote.
Right now, we're trying to figure out what type of stroke you had so that we can treat it, okay?
I had a stroke? That's impossible. Old people get strokes. I mean, whatever this is, it's just temporary. It has to be. So, hi. My neighbor was about here earlier. I have her kids with me. Her name is Ellie Shore. Okay. If by some chance this is a stroke, it's minor. It has to be. I can think, I can hear, I can feel, right? Am I drooling? Yeah, I am drooling. Ellie, this will make you more comfortable. Smiling. Maybe that means it's not so bad. But she's the nurse. Maybe she doesn't know. Okay, Ellie, I'm gonna look in your mouth. Right? She's a doctor. She's not smiling as much. Maybe she's just more serious. No gag reflex. Maybe not.
Swollen muscles are weak on the right side.
This one, he is gorgeous. What is he, 6'4", 6'5"?
Ellie, you have to put a tube in your throat to protect your airway.
Can they come in? Yeah, okay, just for a minute. Ellie, kids are here. They are?
She can hear you better if you guys stand over there.
Why? Because your mom is having a little trouble moving the right side of her body right now. Hi, guys. Don't be scared, okay? Is that why her face looks funny? Oh, is she dying?
No,
Honey, no. Mommy's not dying. She's gonna be fine.
Did you see the last?
Right after school, she was fine. Ma'am, I think you should take her outside. Why is she doing that? Well, we just give her a little help breathing, okay? She'll be fine. Come on, kids. Let the doctor take care of your mom, okay? It's so funny.
Sleep now. When you wake up, you'll be breathing really hard.
Oh, God. Am I dead? Is this it? Is this death? No, something's wrong. I can't open my eyes. I can't move. Somebody help me.
Well, there's no evidence of hemorrhage, so it's probably a clot.
It's too late for TPA.
It can cause brain bleed if it's done after 3 hours. Our kids saw her a few hours ago. At a rig ride, ER assessment. Too close to take a chance.
Well, what are their options?
I hope that collateral flow can develop. Get her to physical therapy. With a major stroke like this, the chances of a meaningful recovery aren't good. The only other option is the Mercy.
What?
It's a catheter retrieval system. Takes you into the brain through an artery. Allows you to corkscrew the clot out.
And it reverses stroke completely.
It's not without risks.
Oh, God. I'm blind. I can't breathe. Help me. Please, someone. Please, someone. Do something. Someone. Can anybody hear me? Help me. Please, God, help me.
Can I ask you a question?
Yeah.
Did you ask Luca about his kids?
One time. Yeah. Well,
I don't know. Sometimes they... She crying?
to 130, BP's 170 over 92. We have to get her back to the ER. What's going on? When did we tube her? Well, a minute ago. Hey, listen, Allie, it's all right. We're going to help you. I think the accommodate we're up is what it sucks. She's conscious but paranoid.
Jay, coming through.
Oh, God. We tried to get hypertensive. I think the second we're off before the paralytic.
Okay, look, what is good with you?
What did they say? Help me.
What do you want, Tabs?
Help me. Why? Help me. Why isn't anybody doing anything? I swear to God, I'm losing it. I'm on board. I swear to God, I'm losing it.
It's okay. What you're feeling is normal side effects. We gave you a narcotic called fentanyl that'll help ease your discomfort. It'll make you dizzy at first.
Wow.
It'll help calm you.
What is that stuff called again?
When the inflammation medication wears off, you'll be able to open your eyes.
This is good. Really good.
That's all right. Moment in time. It's okay, we got this. You want to execute 10 minutes? Do you remember our head done?
Flashlight still works. Sort of. That's a good sign. Try the light again. Come on. Move. Do it. Come on. Move. Twitch. Jerk. Anything.
That sounds Ben almost agree with you.
Damn it.
You okay in there?
Tube in my throat hurts. Can't pee by myself. Can't walk.
Yeah, you got some gorgeous kids.
Is she talking to me?
I cannot believe you have 3. You look great.
Okay, you've seen my stretch marks. You're not talking to me.
You're in our family room right now. We're hanging in there, okay?
Can they be here? I mean, who's watching? Have they eaten? Has their father come yet? Dear God, what is that?
Yeah, pretty stinky, huh? Welcome to my world. Welcome to your back.
Hey, Mrs. Lacey, how you doing?
Hey. you out of the thing, okay? There you go. I think I love you. So what am I so afraid of? I'm afraid that I'm not sure of. I don't know the rest.
Heart rate's still up. You have more fent yet?
Oh yeah, more of that. Not yet. Do we have money?
Yeah.
No wedding ring.
He's on his way. We can't do anything without his consent.
Sexy accent too. Wonder where he's from. Never tracked him down. He's on his way.
Feeling any better, Allie?
What big stride you think you have? This is pathetic. This guy touches me and my heart races. What am I for? BP 127/77. Actually, it's pounding now. Okay, this isn't so good. Reporting. What's happening? Look at CT. Get the crash cart.
Just heal that into stable. Try meds first. 6 of it now.
I'm getting dizzy. It's hard to breathe. Ready to a stroke? My
Operation
heart.
can be properly. It can be a form of blood.
Stroke thought it went to your brain. I can't take this. I'm being pushed out. Oh!
Ellie, this is going to slow her heart down. You feel discomfort, but only for a few seconds, okay? What's happening? You and your husband? Yes.
Back in SVT.
Right now, she's in an abnormal heart rate and I'm trying to fix it. We believe something similar may have happened before. Would have allowed a clot to form and move to her brain, causing the stroke. She had a stroke? I need the rhythm strip.
How was the dosage?
Wait. Sage is funny.
2-1 block and everything will cover that. 20 milligrams will pay them?
Slow IV solution. Can you tell me what's happening? Ellie, I'm so sorry. I know this was painful, but this drug allowed us to figure out your heart problem. Now we can give you the proper medication and this won't hurt, okay? Is she awake?
We can't be sure, but she has had spontaneous eye movement. Sinus rhythm at 76.
It's okay, you can come closer. Ellie, can you hear me?
You're here.
Sir?
No, don't cry. No.
There's a
Where'd you
procedure
go?
we want to try called clot extraction.
A catheter is inserted into the groin and then threaded up into the brain.
Clot's identified and then a retrieval system pulls it out.
How you doing, Alex?
If it works, the stroke can be reversed. And if it doesn't?
There are certain risks involved. Infection and other complications that could lead to coma or death. Your heart's back to normal.
So she's not in a coma now? No. The stroke affected the language center of her brain. So she can see and hear, but she cannot communicate. Do you want us to go ahead with the procedure?
Say yes.
What happens if we don't do it? Well, her heart condition is treated, but she won't improve neurologically, but she won't die.
No, Dan, listen to what he's saying. This other thing might fix me.
How long can she live like this?
I can't live this way.
Definitely. I don't know what to do.
Yes, you do. Remember at the lake when we were talking about your cousin, the one who had been in that wreck, and I said I'd rather die than live that way?
It's not like she's a vegetable, man.
This is worse, Dan. I'm aware. I don't even get to be brain
We
dead.
can't do this without your consent.
What about my consent? I consent, damn it. I consent. I consent.
Is that what's best?
Dan, have some balls. If you love me, don't leave me like this.
There's a chance that she can come out of it.
Please, this works. Hear me.
Oh my God. Ellie?
Give consent. Please.
Okay.
Okay, so like I said, that has helped me a lot in kind of caring for their emotional support as I deal with patients. So we're gonna finish up this lecture, and I'm going to go over the Ada County protocols real quick, and then we'll call it good for now. I have, I think 7 resources added in your areas in this chapter, the neurological chapter. Please look at that stuff. And then as soon as I do the videos, I'll show you how to do a cranial nerve exam and a good VAN exam. So we have talked about interventions and how to treat all throughout this lecture, but this is just a kind of a make sure you understand it. So patients with stroke, seizure, hypoglycemia, any problems with their mentation, hypoxia, we're going to always assess and treat and manage those airway, breathing, circulation, primary assessment stuff. Some of the things that we can do: oxygen if their SpO2 is below 94, dextrose. So for basics, if they're altered, we can't give them oral glucose. For advanced, we have D10, which is much better if they're hypoglycemic than D50, and glucagon if we can't get a line. So those are some of the interventions we can do. Hypoglycemia or insulin shock is more serious acutely than hyperglycemic, although there's a lot of sequelae and problems that happen with hyperglycemia as well. If you have to treat the hypoglycemia, please ensure that the IV line is patent. And again, try to give D10 and not D50, but we're going to make sure that that patency is there in the IV every 10 or so cc's. Make sure the patient doesn't aspirate, keep suction around if they're altered. And for hyperglycemia, we support the airway, breathing, circulation, give them oxygen if they need it, get them to the hospital. Advanced folks can start an IV and give them a little fluid bolus, but they're going to need some interventions that we don't do pre-hospitally. Strokes, again, airway, breathing, circulation support, supplemental oxygen only if they're below 94%. And advanced, start an IV, check blood glucose. Okay, I'm not sure where I left off, but oxygen if their SpO2 is lower than 94. IV access, get your blood glucose. Unless you're concerned about possible spinal injury, elevate the head 30 degrees, and that's just to protect their airway from their swallowing and stuff to help them clear that airway. Watch for seizures. Let's see, what else? This is a American Heart Association stroke algorithm. There's a lot of information on it. Pretty much what we've talked about. So clinical EMS assessment and actions right here. We need to limit our on-scene time, early notification to them. ED arrival time, doctor needs to assess them quickly, get them to the CT, and figure out what they need to do next. Medical care for TIAs, you're not going to know if it's a TIA versus a stroke usually if it's still happening. So treat them, encourage them to go if it goes away. Seizures, we've talked about, protect them. It seems to me anecdotally that when they're postictal and I administer oxygen, keep their airway clear, keep them on their side kind of thing, suction if I need to. The oxygen helps them clear faster and get normal, but that's anecdotal. it has nothing to do with scientific data. So get IV access as an advanced, check their sugar. It might be the seizures caused by hypoglycemia. If it is, treat the hypoglycemia and the seizure will go away. Syncopal episodes, look for trauma, ask what happened. So spinal precautions as needed, check their sugar, check their heart, do an EKG if you can. You know, all the basics. Headaches, we don't usually have to deal with at all. But if their sign or their symptom that they have that they've had the worst headache of their life just started, could be indication that they have a bleed or something going on. Check their pupils, airway breathing support and all that. Dark, quiet, you know, that sort of thing. Okay, that is that. So now what I'm gonna do is share, I don't know what this just did. So now I'm gonna share stroke protocol, which is right here from Ada County. Try to make it bigger here. Well, not that neat. I'm trying, people. Wow. Okay, so this is their appendix. So this isn't the stroke protocol, but it kind of tells you what to do. Minimum time assessment should combine the use of Van and Cincinnati. Initial assessment, check blood glucose, get vitals, suspected stroke. Yes. Cincinnati stroke scale and Van scale with arm weakness. Yes. If that's positive, code stroke, get to the hospital quickly. So stroke suspected, no, proceed with the call. Negative Cincinnati, pre-hospital stroke scale, that's what CPSS is. If they're positive, it's a code stroke, even if they're Van negative. And negative Van findings, go to the nearest hospital. So here's your Cincinnati stroke scale. So facial droop, both sides of their face move equally as normal. Facial droop is not normal. Arm drift, have their hold their hands out, arms extended, palms up, eyes closed. Have the patient say something normal is they can use without slurring, abnormal, they're slurring, or they use the wrong words, or they're unable to speak at all. One of three signs is abnormal. The probability of a stroke is 72%. Last known well is very important. Get the number, past medical history, drugs, or past medical history, medications, allergies, and get going. So the Van assessment. So I wanted to show you this for the large vessel occlusions. How weak is a patient on one side? If they're weak at all, do the Van assessment. So visual disturbance. And we're not doing 4 quadrants, we're just doing 2. Okay, so not 4, just 2. How many fingers am I holding up? Look at my nose. How many fingers am I holding up to the right? How many on the left? Do you see double? Is blindness new onset? Aphasia, expressive, inability to speak or errors. So I want you to hold up your pen or your phone. What is this? Receptive is they're unable to process what you're saying. So have them close their eyes, make a fist, see if it's off. And if one of these is off, they're Van positive. Neglect, if their gaze is forced or they're unable to track to one side, if they're unable to feel both sides of their body at the same time, and they're ignoring one side. Okay, and then this is that again. Cool. Okay, this is their protocol for Ada County, and I just wanted you guys to see this. minimize seeing time. I just want you to read it, okay? I'm not going to read it out loud to you. I'm just going to point out things. This assess blood glucose, last known well, is very important. Call it brain attack or code stroke if they're Cincinnati positive and or VAN positive. In the acute onset, less than 24 hours, an end goal of 2 IV lines is desirable to facilitate the cath lab. Well, the thrombolytic care, not cath lab. Preference is to have at least one minimal, one single lumen IV, which is, we try to get an 18 or 16 in the right AC. Get your blood glucose, be prepared for seizures. So make sure that you correct hypoglycemia. We don't need their blood pressure to go low. Expedite. And this is interesting, which I'm going to give you a podcast that's going to talk about cerebellar strokes in a bit. Somehow I will. This is the precise neuro exam for cranial nerves. This is one of the EMS stroke screens for FAST and VAN. Okay, and then there's something else I think that I gave you. So if you have any questions, let me know. I'm gonna share podcasts and videos of me performing those stroke skills and stuff. And you guys have a great night. Thank you.